Hey Jim, what is that?
That's the doctor's computer.
Oh,
Yeah, so you don't
Gee,
see
I thought
everybody
something
that's
blew
on
up.
there. I forgot to ask, after all that.
Monkey around with that a little
Zoom
bit.
box.
That's okay. Why you introduce
by now you know that Dr. Kucher is going to be our speaker today. And let me give you a little bit of the background on the doctor. He's a board certified vascular surgeon, and he works with vascular experts whose offices are in Darien, Norwalk, and Stanford, as well as Stratford. His hospital affiliations are also Stanford, Greenwich, and Norwalk. Dr. Kucher completed his medical training at Pavlov Medical University in St. Petersburg, Russia, and followed through with the University of Pennsylvania. Dr. Kucher this morning will be addressing some of the latest ultrasound technology, along with other advances being made in his field of expertise. Now, as patients, we all look for several qualities when we look at a doctor. Things like trust, reliability, respect, and communication. Now, if you look that up in Webster's dictionary, under each one of those things, you'll find a picture of Dr. Kucher. Dr. Kucher to me is what I call the man with the golden hands. Why? Well, they diagnosed me, or he and his team diagnosed me, going back a number of years ago, with several blockages in both my legs. And now I'm the proud owner of several of his stents. So, ladies and gentlemen, welcome a man with the golden hands, Dr. Kucher.
Just a note for people online, excuse me, Doctor. We are not able to put his slides on the Zoom call today, so we will try to get them a download of that from him so we can put it on the website so you can look at them later.
That's great.
Go ahead, Doctor.
Thank you. Okay. Microphone?
Yes, but I'll have to turn it up. Go ahead, Doctor.
Okay. Thank you for the introduction. It was amazing. Thank you. All right, so I'm a vascular surgeon, and I work for the company that is called the Vascular Expert, which was formerly Southern Connecticut Vascular. Can we project the slides?
Jim? Yeah, he's
Yep, come in.
putting that on right now.
One screen went to sleep.
I don't have my
Oh,
glasses, so I gotta do this one. Prescription. These are prescriptions that are so dark.
There's little things going on here. Oops. Can reach this.
Oh,
Just have to change it.
okay. It's back.
It's kind of weird, it doesn't usually do that. We'll start from the beginning.
Yeah.
Give that a moment. There it is.
Okay. All right. So unfortunately, we could not bring the ultrasound tech because of the COVID and unclear what the ramifications of touching people outside of the medical facility. But in any case, so specifically ultrasound is one of the ways to reduce the impact on the body when we do something. It's used for diagnostic and also for therapeutic means of treating and finding out what's wrong with patients. So this is one of the typical t-shirts that ultrasound techs wear. It says, I can see with sound. What is your superpower? So it actually is not complete. They're actually missing a punchline. That sound also cannot be heard because it's ultrasound, right? So the full superpower is I can see with the sound that nobody can hear. So anyway, let's go back to the vascular part. So what is vascular surgery in general? Vascular surgery treats arteries and veins, which are basically tubes connecting heart to everywhere in the body. So the vessels deliver oxygen and nutrients and return the blood back to the heart. That's to simplify it. So, the arteries. The arteries bring the blood from the heart to all the organs and basically perfuse them so that they will be able to function, and they deliver oxygen and nutrients. So arteries are under high pressure because the blood flow in the arteries is pumped by the heart, and they're multilayered, and they are prone to develop plaque because of the shear force of the flow. They also can aneurysmally dilate, become enlarged, and possibly have risk of rupture because of the high pressure. So the arterial blood supply is paramount, and without it, the end organ will suffer and possibly die. So you can develop things like stroke, heart attack, depending on which vessel is suffering. So the main risk factors for the arterial disease are cholesterol imbalance, and this is the picture of various pathways, and smoking. So, but those two are easy to address nowadays, right? You can stop smoking. There's a lot of things you can do for that. And cholesterol is relatively easily controlled with the medications. This is a gangrene of the toes. So this, you can see the two toes are black. That by itself doesn't spread, which is a common question whether gangrene can spread. No, it's just basically those toes didn't have enough blood flow and they died. And then eventually something will need to be done with that. But more importantly, you know, can it heal if we do something to them, right? So that's where the blood supply is paramount. That's what we do. We see patients like that and we reestablish the blood flow so they can heal.
Can something be done?
By Jim's mic.
So there's a lot of treatment options. There's a busy slide. The point of it is to be busy, so it just shows that there is so many different things we can do. We can open up the blockage, we can remove the plaque, we can go around the blockage with bypass. So any kind of way to provide the flow from where it's open to where it's needed. So on the most simple one, and that's what you hear a lot, is using balloon angioplasty. Basically, we put a wire through the blockage, and then we inflate the balloon. And if the artery recoils, then we put a stent. Stent is like a wire mesh that basically provides a framework so the vessel stays open. And then recently, in the vascular, and for a while already in the cardiac field, the stents are coated with the specific drugs to reduce the risk of reclosing. The other option is to use devices to remove the plaque, and in that case, you may not need stent. So this is one of the devices. It basically shaves off portions of the plaque. It's called Silahawk. This is a little video of another device. Basically, we enter the vessel, and everything what we do in the office and even in the hospital is frequently done endovascular, meaning from inside of the vessel. No incisions, everything from inside, right? So this is the calcified plaque. This one will be hard to shave off with the device that you saw before. So the different device here is called Silahawk, and it basically will, and this one, I'm sorry, this is Diamondback, the previous one was Silahawk. The Diamondback basically drills the pathway. It softens the plaque and removes some of the particles. The particles then get absorbed and removed by kidneys. And then after that, you do balloon angioplasty, and you don't probably need a stent. So, the other option is to do open surgery. We still do sometimes open surgery for specific situations. For instance, for carotid endarterectomy, some people use stents preferentially, other people use open surgery. So we make a small opening, remove all the plaque, and then put a patch to widen it up. So that surgery has been around for 50 years and is doing really well long term. So, but it's more invasive, so people tend to prefer less invasive options, such as stent. So the other option is to do a bypass, right? To go from the point where the artery is open to another point where it reopens around the blockage. And this is the graft sewn onto the artery on the picture. And now we'll transition to different pathology, right? Now we're talking about the wall of the artery being abnormally weak, and the artery starts to dilate. Again, this is something that occurs in a certain percentage of patients, and it's mostly genetically linked. So if you have family members with aneurysms, it's not a bad idea to get screening. And also smoking. Smoking increases the risk of aneurysm growth and increases the rate. So this is a typical pictures that we see. We get a CAT scan, and then CAT scan is required to get the planning for surgery. But as a screening test, ultrasound is excellent and sufficient to see what size of the aneurysm there is. If it reaches a certain size, which is some people use 5 or 5.5 centimeter, is when we decide to operate. Then we get a CAT scan to see how we can fix it. So in the past, the only option was to do open surgery. That is almost not done at all anymore because we have endovascular approach. Again, through needle sticks in the groins, we can deploy the graft that would seal off the aneurysm and maintain the flow through the vessels. Here's another little video of the graft being deployed. So the graft is positioned right below the renal arteries, so you maintain flow to kidneys. And then the graft is deployed with an X-ray guidance, and that way we ensure that you exclude the aneurysm and maintain flow to vital organs at the same time. So the beauty of that procedure is quick, and it's done with just 2 needle sticks in the groins, and people can be discharged. They can be discharged right away, but they stay overnight for just observation. So there's the top part of the graft being deployed. The bottom is already done. I didn't want to spend too much time showing, but that's approximately how it's done. You push and pull, and it's delivered. There are multiple grafts, and they can accommodate various anatomies. So we're very well prepared for almost anything that has to do with aneurysmal disease at this point. So let's switch now to venous, so to say, nature. So what is a vein? So vein is a thin-walled vessel that brings back blood from the end organs to the heart, so it can be pumped again. So the veins are thin-walled. They have very low pressure, and they almost never become aneurysmal or develop plaque. The problems with the veins is that they can develop clots, which is deep vein thrombosis, or they develop leaky valves, and that can cause swelling. So here's the typical picture of the leg. There are multiple veins that drain the legs. So the blood return in the veins is passive against the gravity. So when you're standing or you're sitting, the blood has to overcome the hydrostatic column to return back, right? So when people sleep, when they're horizontal, there's no pressure gradient, the blood easily comes back to the heart. But when they're standing, the blood has to overcome the hydrostatic column of fluid, and that can create swelling, like tiredness, heaviness, cramps, all of those symptoms. What helps is to use compression stockings, because they squeeze the veins that push the blood to go back up, and elevate legs. Those are typical first steps. If you have superficial vein reflux, which is when the vein becomes dilated, it has leaky valve, those veins can be removed or just shut down. Most of the times we don't remove them physically, we just shut them down. In the past, people used to remove superficial veins because you don't need those veins. They don't have any function. So taking them out actually will help with the blood return. Currently, we treat vein problems without incisions and actually with just local anesthetic, not on sedation. There's a patient with a venous stasis ulcer comes to me, This is me doing the vein ablation procedure. Patient is fully awake, even though it looks like it's prepped, but it's done in an ultrasound room with the ultrasound tech. And a couple months later, it's all healed, and the patient can go back to normal activities. So there are various ways to treat the veins. This is a short vein. It's called perforating vein that's being treated. So a different problem with the veins, and more significant and something that may need to be treated more urgently, is deep vein thrombosis. There's a triad of problems that create that situation. Hypocoagulability is a very important part of it, meaning that your blood is too thick. And it can be genetic, it can be dehydration, it can be related to some cancer or any other condition. Additionally to that, vessel wall injury or any trauma, so the clots are more commonly forming when people develop during the surgery or right after surgery. And stasis, meaning that reduced flow, again, more common during the surgery. So when they do ultrasound, again, ultrasound is an ideal study to diagnose it. They just see no flow in that vein. So one of the ways that people prevent the most feared complication, which is pulmonary embolism, is to put an umbrella, which is inferior vena cava filter. There are various types of filters, but for the most part now they're all conical shaped. And they sit in the middle of the belly and catch the clots from the legs. That umbrella can then be removed when you don't need it anymore. So most typical situation when we put it in and remove it is somebody with known history of clots undergoing orthopedic surgery, knee replacement or hip replacement. Clots during that surgeries are very common. So if patient is already known to be prone to getting clots, we can protect them from getting pulmonary embolism by putting filter, which is done, takes about 10 minutes. They stick in the groin, we put the filter, patient goes home right away. And the retrieval will usually go from above, but also takes about 20 minutes. We grab the tip of the filter with a special hook and then just take it out. So once they have their surgery and fully recovered, so they're not at risk anymore, we take out the filter. The other things we do with the clots is if people have a lot of swelling, we can remove the clots. One of the ways is to use suction devices, like this one is angiojet. The other one is use lysis, meaning a clot buster, a medication that causes clot to be dissolved. And some of them have additional features, like this one, for instance, on the picture, uses ultrasound to increase the contact between the medication and the clot, so it dissolves faster. So sometimes veins can be compressed by the other structures. Like in this case, the artery sits on top of the vein. Again, the artery is under high pressure, thick-walled, and the vein is thin-walled. And when the vein compressed like that can create a lot of backup pressure in the leg and cause swelling and increase a little bit the risk of getting clots in the leg as well. So we can put a stent, and the stent will keep the vein open and maintain a good flow in it. So when we do that, we usually use ultrasound that's inside of the vessel. Intravascular ultrasound. So basically there's a small tiny ultrasound that goes through the needle stick again, and it looks from inside on the vein and shows where the compression might be. Here's how it looks when we pull back the catheter. So we see the black circle in the middle, that's the vein. So it's normal right now, and there's a stent in it, and we can see where it gets compressed, and then we can treat it with additional stenting or, as needed. Sometimes the intravascular ultrasound allow us to diagnose other features like calcifications or side branches or other things. And again, it has no risk. There's no radiation, there's no contrast, so it's one of the least invasive ways to diagnose things. And then when we see the vein, when we inject the contrast in the veins, we can see sometimes vein compression, sometimes you can't really see it. Here's a picture where the stent is placed on top. It might be a little bit hard to see, but you can see there's a very tight spot right below the stent, so it needs additional stenting. And after that, the patient will have good flow throughout the vein and reduce the swelling, tiredness, and all the other symptoms. So this is a brief overview of vascular surgery, current technology, and a little bit of the ultrasound specifically. So if you have any questions? Yeah.
Doctor, what percent would you say of the population has one or a combination of any of these ailments?
So it depends on age. Everything, just like playing lottery, the more you play, the more you win. So with age, you get more of anything, right? The question is not so much whether you have it or not, but whether you need something done or not. Over a certain age, probably a majority of people have developed plaque in the arteries. It doesn't necessarily mean that it needs to be treated, right? So if you do ultrasound of people, say 70, 80 years old, pretty much everybody will have some plaque, and even some narrowing. For the most part, if there is no symptoms associated with it, it doesn't need to be treated, right? So the vein problems, the varicose veins, are also very common and also undertreated. Those we do a lot more liberally if there are any symptoms, because you don't need superficial veins, they don't have any function. So if patients benefit from ablating, you know, why not, right, if they have any symptoms. So that's the idea. But the disease itself is quite common, it's quite prevalent. So I would say, again, yeah.
I'm sorry, I have another question. So,
Microphone this time.
oh, microphone is okay. So with that being said, that people upper ages are more subject to these issues, is there any kind of, rather than, if you find someone who's not a smoker, who doesn't have high cholesterol, who, you know, works out, seems to be in good shape, yet dies of a heart attack, what kind of symptoms or things could you look for ahead of time to figure out that there's a problem brewing and that might happen?
So for the most part, cholesterol is the main factor that influences that risk, right? So people frequently say, well, I never smoked, how can I have a heart disease or whatnot? And for the most part, that's genetic. The amount of cholesterol that you have and the balance of high density and low density is what would influence your deposition of a plaque. So there are people who, you know, are lucky they have high levels of good cholesterol and bad levels of bad cholesterol, low levels of bad cholesterol, and they live to 100, the whole family. They can all smoke and they still do okay. They can get lung cancer, but they usually don't get plaque, right? And then there are families who exercise and do everything right, and everybody drops dead at 40. But that's usually because their cholesterol levels are really high. The good news, though, is that there are medications that can kind of even the playing field. Because if you start taking statins, you can control cholesterol fairly well. So obviously smoking is the easiest thing to address. Well, some people it's not the easiest thing to address, but that's the first thing to address, I would say. So those are the main factors. Everything else is sort of, you know, there are some influences of diabetes, there are some influences of renal failure on arterial disease, but if you can control at least those two factors, it will be, for the most part, safe from arterial disease or heart attacks. So.
I guess I'm going to live to 100 then.
Yeah, good call. Yeah, well, lucky you. Yeah, good genes.
Jim,
only a
Jim,
running
I have
now.
a question.
Next
I
question.
want to find out if we have questions.
I have a question. You gave us a pretty good overview in about 20 minutes or so, and now we're all experts, right? How many years of education does it take to get to where you are? And I know you do continuing ed too.
So this is interesting. Like a lot of people say that vascular surgery is glorified plumbing because all it is fixing tubes, right? So it shouldn't be that complicated, right? It's an interesting question. Most of what I do, I wasn't trained to do, right? You learn as you do a lot of things, additional devices, additional this and that, right? And that's how most of the things are. When you start working, you have basic knowledge, you're trained to do some bypass, but most of those stent things and minimally invasive procedures, you pick up as you go down the street. It's more of understanding the pathology, the mechanisms, what works, what doesn't work, what's safe, what's not safe, and that takes a lot of years, right? So typically, here in the US, people spend 4 years of undergrad, 4 years of medical school. For surgery, then you usually spend 5 years, or sometimes with research, 6 or 7 years for general surgery, and then additionally 2 years for vascular surgery fellowship. That's the typical path for vascular surgery.
And then you have to keep up. You have to keep
Well,
up.
you do have to keep up, and a lot of what you taught, you pick up from the meetings, from your colleagues.
Yeah.
Sometimes the reps of the companies will show you a device, and you kind of go with it, just try and see how it works. So it's not uncommon. There's no specific training at all for things we use.
Hi, I just had a question. I know you said that diabetes and not smoking is gonna, you're gonna be in good health. But anything else preventative, like, are you familiar with research about K2, vitamin K2 for vascular health?
So there are two different things, again, arteries and the veins, right? So for arteries, it's mostly atherosclerosis that we're talking about. And being active, being physically active is one really important thing. It does help you control your cholesterol, and it does lower your blood pressure at rest. So it does have a lot of positive factors. People always say eat healthy. If your cholesterol levels are super high, you won't be able to control with diet alone. You won't need medication anyway. But obviously eating healthy is a good idea, but it's really less important than smoking cessation. If you need statins, so you really need them. You can't really avoid it.
But as far as K2 goes, you don't really know anything about that or the research with that K2 for vascular health, vitamin K2?
Vitamin K2.
Yeah.
I don't know anything about vitamin K2. I know that niacin is frequently used to lower cholesterol levels.
Yeah.
So it's one of the...
It's not for cholesterol, it's specifically, they say, for vascular health.
No, I don't know about K2.
Okay.
Vitamin K is involved with the clotting, but I'm not sure about that.
Okay, thank you.
Yeah.
What are some of the symptoms that we can look for when we say to ourselves, I better go see Dr. Kucher?
Yeah. So what we frequently see people with is various symptoms related to legs, like tiredness, heaviness, difficulties walking. The first sign of reduced flow in the arteries is when you walk and you start getting cramps in the calf muscle. That's called claudication. And that's the first sign usually indicating that there is a blockage somewhere. You just don't have enough blood flow when you exercise.
Want me to come with you, honey?
And,
Can you help for me, or is he okay? It's his wrist.
Thanks, Lisa.
And then as it progresses, you can start developing wounds, ulcerations, all other things. And therefore, we start treating it once you start developing symptoms. For the vein problems, it's similar in a sense. It's like tiredness, heaviness, sometimes cramps that bring patients to us. We do ultrasound. If we find superficial vein reflux, we'll treat that. Aneurysms you can't feel. You wouldn't know anything about them. They have to be screened. Carotid artery disease, you usually don't feel either. You don't know that you have it. There is a risk of stroke. For that reason, people who are at risk for getting significant atherosclerotic disease, high cholesterol levels, and smokers probably should get their carotid arteries screened. But that's pretty much what we usually see. It's usually complaints related to leg problems. Yes.
Should an exam of this type be something that, should be like a regular physical for people that are, let's say, 65 or older, maybe every couple of years?
So the Medicare has a specific, welcome to Medicare sort of list of things that they approve. One of them is screening for the aneurysms, we're doing ultrasound. There are live screening things that drive around. They're not very specific, but they kind of see if there's indications of the blockages in the arteries and aneurysmal disease. They do a quick scan. If there's a big aneurysm, they say you need to see a vascular surgeon, or if there's a lot of blockages. They're not free, but they're not really expensive, so a lot of people do that. So frequently we have somebody coming in, live screening, they found this. But usually a primary care doctor can just say, well, there's something funny here, go see a specialist. So that's how most of the patients come to us.
Any other questions here? I want to be able to have people from Zoom if they have any questions. So anyone have a question from Zoom? Kiwa Zoomers. Yeah. I think there's, Dan, you have something? You're on mute, but.
Yeah, hi, Doctor. I just want to ask about what's the risk of vascular damage during a procedure?
Which procedure?
Well, are there particular procedure, in particular, like a plaque removal procedure? Where's the tipping point between getting the plaque removed and avoiding any vascular damage during the procedure, or is that a major risk?
So basically, when you do any intervention, any ballooning, any plaque removal or stenting, the body responds, right? And body responds by developing basically scarring process, right? So your stent can reclose over time, or the artery can start narrowing down soon after you opened it. And we don't really know who responds which way. There are some people who you do studies, in the years from the stent placement, and the stent's wide open. And there are people who restenoze rapidly within a couple of months, and something else needs to be done. And there is no way to even predict who's going to behave which way. But to reduce those things, we use medications like aspirin and Plavix, commonly used. And then the particularly cardiac stents are all medicated now. And that reduces the risk of developing restenosis. The peripheral vascular stents are not really that much of the treated stents. They're basically bare metal for now. But yeah, there are ways to predict. And most of the time we screen people with ultrasound and we follow people with ultrasound. So if we see that narrowing is developing, we can decide to treat if needed. A lot of that depends on symptoms.
Great, thank you.
Yeah.
All right, do we have any other Zoom-based participant questions?
This is Tom Johnson. Am I coming through?
Yes, you are.
Yes. Did you say that I'm coming through? I'm out of the
Yes, I hear you.
Sure what's happening.
Yes, you're coming through, Tom. Go ahead.
Yeah, we can hear you.
We can hear you, Tom. We can hear you, Tom. Go ahead.
Yes, we hear you. Yes. One of the markers for coronavirus is blood oxygen level.
Yeah.
And I never am quite sure as to what is normal or not normal. Could you comment on that?
Sure, absolutely.
For instance, part of the COVID problem is pulmonary infection.
Right. So,
Any thoughts on that?
absolutely. So it's not really infection of the lungs that's the problem. So COVID was particularly unusual because it caused a lot of clotting. Not only pulmonary problems, but frequently completely normal arteries would shut down and clot off, and we'll have to deal with that emergently. But what happens with most people who present with lung problems is that they fill up all their pulmonary arteries, small vessels, with clots. And at that point, the lungs, instead of being light and fluffy, becomes like a solid, like a liver. They're really filled up with a clot, and it takes a long time for it to reopen. So lungs normally filter a lot of clots that are formed in the veins. We don't even know about that, but we frequently have microembolization into the lungs, and the lungs just kind of filter it through and eventually recanalize that. With COVID, it was just such a large volumes that lungs barely functioned in many patients. And that was the main problem. That's how it's different from the rest of the diseases like that, the common cold. Otherwise it wouldn't be as deadly. So what you're talking about is when they measure oxygen in the saturation of the oxygen in the red blood cells. So it's to what extent red blood cells, hemoglobin, is oxygenated, is what they're measuring with the when they put the pulse ox, right? And normal numbers are, depending on your lung conditions, anywhere from 92 and up. Completely normal young people usually show 98% or something like that. But anything out over 90s is fine. There are people with chronic lung disease who normally live in high 80s and kind of do okay. They might get short of breath with exercise, but otherwise they're doing more or less fine. So if you see a drop, particularly if you know your baseline, if you see a drop, you used to measure 95, right? And then suddenly you see it's under 90. That obviously is significant. You probably will be short of breath already. So.
Yeah, thank you.
Absolutely.
Thank you, Tom. Any other questions from Zoom?
I have a question.
Yeah.
Yes, Jackie.
Hi. I was wondering if you could speak to current updates in transcatheter repairs for medium to large ASDs in pediatric patients.
I don't treat heart. That's cardiology.
Okay.
So
You were talking about the groin catheter, the transcatheter
Right.
procedure, so I was wondering if there had been, if you had
there is a lot of
any
developments.
research lately in advances for that.
There's a lot of developments.
In pediatric patients.
Yeah, there's a lot of developments, and right now there's a lot of tools that they have at their disposition. I just don't do that, right? So vascular surgeons treat all the vessels except for the heart and inside of the head. We don't treat those. It's a neurosurgery and cardiac surgery, or cardiology. We do all other piping. So can't really give you a lot of advancements there, but they do have a lot of tools in there at their disposal.
Thank you.
Okay, I think we can take one more question. Is there any others from Zoom? Is Phyllis trying to talk?
Yeah, I did.
Okay, we hear
are
you now.
there?
We are now.
Hello?
We can hear you loud and clear, Phyllis.
I have a question. When veins collapse, what do you think of the procedure that goes in and heats up the vein to make it collapse even more because it's non-functional?
Right, so superficial vein, again, you don't need them at all. They don't have any function. So you can treat all of them and shut them down, and there won't be any downside to that, right? So you wouldn't do it if they have no problems. So if there is a reflux that the ultrasound shows, it's completely fine to treat the veins if you have symptoms. There's pretty much no downside to that. The risk of getting deep vein clots is very low, and we do a lot of those procedures. So that's one thing that you can do safely with, as long as there is an indication that there is a reflux in the superficial vein and there are some symptoms.
I see, thank you.
Yeah, of course.
So Dr. Kucher, thank you so much for
course.
coming today. We really appreciate it. For our speakers, we always have a special gift. So here's our wellness mug, so you can think of us. And I'm sure you will see many of us, given the type of breakfast we eat every Saturday, in the coming years. And thanks for keeping Tom ticking over there.
Of course.
Because he's had a
Thanks
long
for inviting
history. All right, Tom? I said thanks for keeping you going.
Oh, absolutely.
Yeah. Thanks for inviting me. I appreciate it.
Yes, and come back anytime.
Poster boy for sense.
So please come back anytime. You're in the neighborhood. We're always happy to have you. And are we able to put this presentation, recorded version, on, do we put it on YouTube?
Yes.
Is that all right? Do we copy this on YouTube? Excellent, excellent. So we'll definitely do that. So for everyone who had to watch it with